Okay, thanks. Oh, which one you are taking?
Shall we go to the second one, which was more
Sure.
interesting actually?
Yeah, no problem.
So then, if time permits, we'll take the other one.
No, not necessarily.
Yeah, this is the one. Okay, can everybody see the screen now?
Yep. Yes, thank you.
Yeah, so this is a 63-year-old gentleman who presented with lower tract symptoms, basically storage symptoms mainly, increased urinary frequency day and night, urgency, and also reported that he feels that his flow is poor. Next slide. He has been a known diabetic and hypertensive for 10 years. Diabetics are well controlled on oral medication. There is no evidence of microvascular or macrovascular complications, no evidence of neuropathy. And he was seen by a local urologist who examined him, and there was a small prostate, less than 20-30 grams. So he was initiated on an alpha blocker, probably tamsulosin. Next slide. But he did not get much relief even after 3 months of medical management. So he went to him again, and I think he was added an anticholinergics because he was having storage symptoms, was not happy with the medication. So anticholinergic was added. He reported not much improvement. And so the local urologist actually said, now I have tried enough of medication, and I think you would better off with a TORP. The patient somehow decided not to heed that advice and came here to us for a second opinion. Next slide. So on examination, he was otherwise normal, but he had a significant central obesity. His extragenital was normal, prostate clinically benign, about 20 to 25 grams in size. His focused neurological examination was pretty normal. Next slide. When we took proper history, we realized after looking at the central obesity that his wife said he snores a lot and he's pretty often tired during the daytime. And another thing which came up when his wife said that he never listens, he has a very poor compliance with his physician, his diet, about his diabetes. So there are three important things which we found in him, that he was not a very good patient as far as medical treatment for his medical problems were concerned. Next slide. So he had he attended our LUTS clinic where he filled up his diary, and here you find that his IPS symptom score was 17. Quality of life is 5 or 6. He's quite significantly bothered by his nighttime waking up. Next slide. And then he had his voiding diary, which is in front of you, may be difficult for you to read. So I'll give you the findings of the main important findings of his voiding diary in the next slide. So basically his 24-hour fluid intake was about 2.7 liters. Output was about 2,400, maximum voided volume over 300 ml. His daytime frequency was 8 times, nighttime also about 6 to 8 times. And his nocturnal output was more than 1,550 ml. So next slide. Another of his investigation, his renal functions were normal. Blood sugars, I think in the range of 110 and 140. Urine microscopy was normal. This is his flow, which basically after correction of the artifact is around about 10 ml. Voided volume was 260 and his post-void residue was only 30 ml. Next slide. This is the ultrasound abdomen, which is otherwise unremarkable. Apart from a gallbladder stone, he had about 17.4 mm stone in his gallbladder, a small simple cyst in the left kidney, prostate enlarged in size, about 40 ml, with no intravesical significant protrusion. Next slide. So at this point, what would the panel suggest?
So, Nitin, should I comment or let us hear from Paul first?
Sure, why not?
Yeah.
Well, this is a very good case because he's, I think I might be tempted to ask him the first question: how long do you want to live? Because, he's 62, he's getting up what, 6 times at night.
Yeah, 6 to 8 times.
Remember those very good studies done in primary care from Norway, which showed that there was a close association with the number of times a patient had nocturia and early death. And this man, he's obese, he's a diabetic, he's hypertensive, he doesn't take any notice of his doctor, and he's got nocturnal polyuria, and he's also got sleep apnea by the sound of it. So he really has multiple pathologies. He's got metabolic syndrome, and he needs to, he needs somebody to give him a really good talking to in a holistic way. He needs more than a urologist. He needs a diabetologist and a psychologist as well.
Okay, so so in this case, if we, Paul has very nicely summarized the whole thing. And if we see everything in details, this is a case with a nocturnal polyuria, because if the definitions are slightly vague, but there is one definition where if the nocturnal urinary volume is more than 33% of the overall volume. So the first thing which we try to see is whether there is a global polyuria. So it is not there because the output is less than 3 liters, right? And then in this nocturnal polyuria, he's going, if we divide 1500 by 2400, so it is close to 60%. So there is a definite case of nocturnal polyuria for him. Even if we go by the other definition, which is LUP 90, that means output in the night or the intended sleep hours for more than 90 ml per hour. So even if you look at from the NUB or from NUP definition, he definitely fits into nocturnal polyuria. Now coming to the management, we already know that there are some medical causes which we have already ruled out: cardiac failure and a nephrotic syndrome or venous insufficiency. So because creatinine is normal. So, but one very prominent finding is the obstructive sleep apnea. So now these patients who have obstructive sleep apnea, they can have, actually, if you go into the pathophysiology, they can also have nocturnal polyuria. So this patient actually needs a good opinion from the pulmonary as well as from the sleep angle. And I think that is first thing which we should rule out and see whether he can get relief from that. And now going back to Paul's presentation, where he said according to EAU lines, guidelines, we give desmopressin or the furosemide. So furosemide was okay. So my point is that in a scenario like this, of course, here we are going to first see about the obstructive sleep apnea, sleep thing and all. So question to Paul, when do you specifically prescribe desmopressin?
Well, certainly not in somebody like him.
Yeah.
The other issue we haven't talked about is whether I imagine he's not very physically active.
Yeah, he doesn't look like, yeah.
Well, he takes
he's not. He's not.
He probably sits around all day. He's obese, so he will have peripheral edema. So he needs to get rid of the peripheral edema during the night. So if you gave him desmopressin, it would probably be quite dangerous in his case because he's very unfit. We say he's 63, but his biological age is probably closer to between 70 and 80. When you compare all you nice gentlemen sitting there who are more than 60 years old, you are much, much fitter than he is. So looking at age can be very misleading. This is an old man we're looking at.
So my question is, what are the indications for giving desmopressin?
Well, I think the indications are in somebody under 65 who is relatively fit, who has no signs of peripheral edema. Now, detecting peripheral edema is not so easy because, of course, you need to have 1 liter, more than 1 liter in your legs before peripheral edema is obvious. So, you know, most of the patients we see have nocturnal polyuria due to peripheral edema, but the amount of fluid that is in the leg is not enough to detect clinically unless you go round to the man's house in the evening and feel his ankles in the evening. Because, of course, first thing in the morning, he doesn't have fat ankles because he's got rid of all this urine overnight. So we underestimate the importance of exercise and keeping fit. So this is why I say this man needs to be, he needs a total life change, doesn't he? If he also, the other factor with him is if he's not taking any notice of his doctor, he will have 24-hour polyuria because his diabetes is poorly controlled. And he does, in fact, have a 24-hour urine output of 2.5 liters, doesn't he? Which in India, where you're sweating a lot, means you must be drinking a lot of fluid, like Dr. Yandy is. Yeah.
So just for the audience sake, before we go further and Nitin tells us about the management, one more thing which we need to look at through the voiding diary or the bladder diary is the nocturnal bladder capacity index. That is very, very important because there are some patients who will have nocturia and you will see that, you know, they have been able to, the maximum avoided volume during the day was only say 150 or less. So those things are also important when you take it to consideration. So, okay, I think we go to Nitin and then,
I think
yeah. So what did you do? Yeah.
Sir, if you look at the bladder diary, he was drinking a lot of water in the night too.
He wakes up and drinks water.
Yeah, that's another big problem, that it's just not the nocturnal output, not sleep apnea, not the ANP which is being produced, but I think the amount of fluid he ingests in the night is an important aspect to consider before we start doing something for him.
Okay, so I agree, and I think morning the lecture of Professor Paul Abraham was very, very clear. So can we have the next slide, please? So he was, as said, we sent him to pulmonary medicine. He had his sleep studies, and he was found to have a significant obstructive sleep apnea, and he was advised CPAP. Equally, he was advised lots of lifestyle modification for his central obesity, overweight, fluid intake. We was slowly put on daily aerobic exercises and weight loss, strict diet control, diabetes control. And with that itself, within no time, actually, when he started his CPAP, his nocturia significantly improved. And he is, I mean, he's recently been seen only about probably 6 weeks ago. He's significantly happy with his nighttime symptoms and his quality of life. The only thing when last time he was reviewed and when I asked him, he's happy about everything, but he still feels that his flow is not good. As we have seen, his flow is around 10 to 12 ml. But when I asked him, he said, I'm quite happy to live with this flow. I have never been sleeping so well.
Well done. You've done a very good job.
Okay, so I think in the interest of time,
operation. Hello?
Yeah.
So he basically came here because he didn't want to undergo surgery. Not that he had any idea that he has got this sleep apnea. So it's a big problem in our society when the people are not under a general physician's care all the time. They go and see a diabetic doctor, they get a treatment and they forget about it. And it is mostly, they've come with a lot of complex metabolic syndrome and other complications. So the message I put this case is that, he was advised by TRP by a urologist. So it is the same message that a lot of people in community urology may not recognize this. It is very, very important not to confuse nocturia always with a bladder outlet obstruction and not to. But the next question here is that tomorrow when he comes back after 3 months or 6 months and does not improve his flow, what would you do?
Hello.
Anish, could you get that?
Yeah. Okay. So your question is that this patient you could manage well, and his quality of life has improved. He's able to sleep well in the night. The nocturnal polyuria thing is quite under control. But he was never unhappy with his flow. Is that right?
No, he did complain that my urine has slowed down.
Have
Yeah.
you
His
done,
original,
have you
his
done
original
Euroflow
complaint
studies?
also, he mentioned that I pass urine slowly. But when he was bothered by his nocturia, he was not that much concentrating on his flow. Now what has happened, his nocturia has settled. He is just improving. Last time when the last review, when I asked him everything is fine, he said very happy. But he said my flow hasn't improved, but I'm okay with it.
Paul, please.
Well, I would just say, I think I would say you've done really well. And I suggest I see you again in a year's time. And by that time, hopefully you will have lost some more weight and we can measure your flow rate. So I think you've done a very good job with him. And it's disappointing that so many of our colleagues cannot treat patients in this way. They don't understand nocturia and the causes of nocturia in particular.
So thank you. I think in the interest of time, shall we